Observe the gait as the patient enters the examination room. Look for a head tilt. Ocular tilt reaction is observed by the positions of both eyes in relation to the horizontal plane. Before doing the cover-uncover test, we must always perform the cover test first to exclude already manifest strabismus. One eye is covered with the examiner's forefingers for 10 seconds and then uncovered to look for the movement of the uncovered eye. The examiner covers the patient's one eye with 4 fingers, then moves the cover to the patient's other eye while looking for a vertical corrective movement as an index of vertical misalignment. This is used to detect skew deviation. Spontaneous nystagmus can occur with both central and peripheral lesions. 20-diopter Frenzel goggles or microglasses are used to enhance the spontaneous nystagmus. These high diopter glasses remove fixation. Note that the central nystagmus is not fatigable. For horizontal saccades, ask the patient to stabilize their own head as shown. The examiner shows folding and unfolding of the index finger horizontally and vertically at 30-degree angles from the midline, alternatively for the patient to focus on. The patient is asked to follow the examiner's 2 fingers moving 10 to 20 degrees per second in a vertical and horizontal direction, like a rectangle. Do not move the finger far away from the visual field. Keep the examiner's 2 fingers in 9 extended positions. You can use a card for the 2 fingers. Do not go to the extremes of the visual field. The finger is kept in one position for about 5 seconds, then moved to the next. First, start at the horizontal level and look for nystagmus. In peripheral lesions, we can see slow and fast components easily. The examiner shows 2 fingers in a horizontal plane, near and far as shown. Ask the patient to focus on each finger alternatively. Or, while the examiner is moving her index finger near and far in a horizontal line, ask the patient to keep focusing on the finger. Stabilize the patient's head and ask to fixate the eyes on the examiner's nose. Turn the head horizontally towards one side briskly and repeat the same on both sides for 5 times. To suppress an intact VOR, the patient keeps the thumbs together and moves right and left circumferentially, keeping the eyes focused on the thumb nails. This can be done with pneumatic otoscopy or episodic tragal pressure. Watch for nystagmus of deviation of the eye. Optokinetic nystagmus can be elicited with a horizontal and vertical moving strips software. Ask the patient to focus on the dot or one strip. Closely observe the patient's eyes for nystagmus. Alternatively, we can use a bucket with pasted pictures and rotate the bucket in its own vertical and horizontal axis. Ask the patient to focus on one picture. Closely observe the patient's eyes for nystagmus. Subjective visual vertigo can be easily measured with a plastic bucket. Mark a vertical line inside the bucket and paste a protractor underneath. Attach a thread to the midpoint of the bottom with a weight. The patient is blindfolded to the surroundings by inserting the head into the bucket. The patient is asked to stop the rotation when he sees the line vertically straight. The degree of deviation from the vertical is measured with the protractor. Ask the patient to touch the examiner's repeatedly moving finger with her index finger. Repeat this procedure for both hands. Look for fast pointing. Ask the patient to do repeated pronation and supination of the forearm. Repeat the same procedure for the other hand. Look for incoordination. Ask the patient to keep the feet close together while standing and close the eyes. Look for unsteadiness or fall. Ask the patient to keep the foot one after the other in a straight line and repeat the same procedure. Then ask the patient to stand on one foot while the eyes are open and then eyes closed. Look for unsteadiness. Ask the patient to stand on a cushion, first with the eyes open and then eyes closed. The examiner should be ready to hold the patient if she falls. Ask the patient to walk in a straight line in a tandem manner and look for unsteadiness. With the patient lying supine, instruct her to place her right heel on her left shin, just below the knee, and then slide it down over the shin to the top of her foot. Repeat the same for the other leg. Exclude severe cervical spondylosis before this procedure. Get the patient to sit on the edge of the bed as shown. Most patients have right-sided vertigo. Therefore, start from the right. Turn the head 45 degrees to the right. Make the patient lie down with the head hanging down 30 degrees from the horizontal plane, from the edge of the bed. Ask the patient to look straight ahead. Watch for nystagmus. Make the patient sit up when the nystagmus settles. Repeat the same procedure if there is nystagmus to see fatigability. Nystagmus becomes less with repeated positioning due to fatigability. Do the same process on the left too. The subject is seated at the side of the bed and with the head turned to the left. Then the subject is made to lean to the right side and observe the nystagmus. Now turn the head to the right and lie down on the left side and observe for nystagmus. In a patient with vertigo, supine and erect blood pressure monitoring is of value to exclude any medical conditions.